بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the third part of the lecture of the imaging of arthropathies, and you remember that we have discussed these issues, the polyarthritis of unknown etiology, connective tissue disorders, arthritis with inflammatory bowel disease, biochemical and endocrinal arthropathies. Now we'll discuss the remaining topics, including the degenerative joint disease, osteoarthritis, septic arthritis, traumatic arthritis, neuropathic arthropathy, some of the neoplastic arthropathies, which describe some of the tumors arising intrinsically inside the joint itself. And finally, we end by some of the miscellaneous disorders that can also be seen in some joints. Now, the osteoarthritis is a well-known disease, and we have two main types, the primary type and the secondary type. And there is also a type which is known as erosive osteoarthritis, which is almost confined to the small joints of the hand, and maybe only seen in females in particular. In primary osteoarthritis is a degenerative disease of occurring without an underlying joint pathology, and it is usually seen in women, this arthropathy or arthritis in the hand. It may present also in the erosive type, as I will discuss, and this is the most common distribution of osteoarthritis in the hands. You can see that it affects mainly the distal interphalangeal joints as well as the proximal interphalangeal joints, some of the metacarpophalangeal joints, and you can see that all the joints of the thumb are affected, including the metacarpophalangeal and the metacarpal joint, and also this particular joint between the scaphoid and the trapezium. All these joints can be affected by or commonly affected by osteoarthritis if it occurs in the hands. Then there are particular manifestations of osteoarthritis all over the body, as you all know, including narrowing of the joint space, subarticular bone sclerosis, osteophytic lipping of the articular surfaces. And here in the hand we have a particular appearances where bony protrusions of the dorsal margin of the distal interphalangeal joint, as you can see here, which is known as a Burden's nodes. And if these bony protrusions are also seen in relation to the proximal interphalangeal joint, they are known as Burkhardt nodes. These nodes are, as you can see here, are less common compared to those of the Burden's nodes. And this is a photograph of the hand showing both types of nodes, the Burden's nodes occurring in relation to the distal interphalangeal joints, and the Burkhardt nodes occurring in relation to the proximal interphalangeal joints. And here are the manifestations by radiography. There is in any type of osteoarthritis, of course, as you all know, there is a joint space narrowing, subarticular or subchondral bone sclerosis, and osteophytic lipping of the articular surfaces. And in advanced cases you can see subarticular pseudocystic changes, as you can see these radiolucent small cysts. And in the hand there may be other manifestations like very small microfractures that are seen with magnification radiographs. Also some areas of ischemic bone necrosis. There may be alignment deformities, and sometimes you can see perosteal new bone formation. One of the appearances of the osteoarthritis in the hand, especially in the distal interphalangeal joint, is that appearance which is almost similar to the bird in the sky, or the gull wings, as you can see here. If I magnify this image, and you can appreciate this appearance in relation to the bird in the sky. This is just a simulation between what happens in the joint. There is narrowing of the joint space. There is subarticular bone sclerosis, osteophytic clipping of the articular surfaces. And this is an advanced case of osteoarthritis of the distal interphalangeal joints of most of the fingers, showing the typical appearance. There is narrowing of the joint space, subarticular bone sclerosis, osteophytic clipping of the articular surfaces. This type of osteoarthritis, which is known as the erosive osteoarthritis, is considered an inflammatory form of osteoarthritis, which is, as I have said, limited to the hands, and usually seen in postmenopausal women. The interphalangeal joints, as well as the trapeziometacarpal joints, are mainly affected, and there is sometimes severe shortening of the fingers, producing this ménonargent deformity. And you see here the erosive type of osteoarthritis, which is almost closely similar to the degenerative osteoarthritis, especially if you have the radiographs of the hand. But if you have the close magnified radiographs, you may see some of the erosive changes, as I will show to you. And here you can see the degenerative changes in the proximal and the distal interphalangeal joints of most of the fingers. Also, you see the affection of this particular joint, which is the metacarpal joint of the thumb, as well as the joint between the scaphoid and the trapezium. And this is a close radiograph where you can see these changes. First, you see loss of the joint space. There is almost total obliteration of the joint. Then erosion of the subchondral bone. You see these erosions and osteolytic areas in the subchondral bone, like these osteolytic areas, and ending by pseudojoint. There is a false articulation between the phalanx and the phalanges, and there is extensive irregularity of the articular surface. Also here you can see by plain X-ray and by MRI, and these what we call the microfractures and the subarticular pseudocystic changes. You can see the changes in the plain film and also in the T1 and T2 weighted images by MRI. And this is also an example of the erosive osteoarthritis of the distal interphalangeal joint, and you can see some kind of subluxation of the affected joint. And also this is an example. There is marked narrowing of the joint space, subarticular bone sclerosis, irregularity of the articular surface, osteophytic clipping of the at the joint line. Then the primary osteoarthritis in the big joints is a well-known disease and easily appreciated from the plain X-ray, and these are the the findings: narrowing of the joint space, subchondral bone sclerosis, marginal osteophytic clipping, subchondral pseudocystic changes, intra-articular gas, or what we call vacuum phenomena, and the presence of loose bodies which represent the fractured osteophytes. Loose bodies, of course, are seen in the big joints, especially the knee, the elbow, and the hip joint. Then, this is an appearance of osteoarthritis of the knee. There is significant narrowing of the medial compartment of the joint space, subarticular bone sclerosis, osteophytic clipping, and intra-articular air. And by X-ray you can also see the calcified loose bodies in the posterior compartment of the joint. And also you remember that if the loose bodies are sizable, they will develop bone marrow and the cortex. They will show similar MRI appearance to the femur and tibia. And this is a severe form of osteoarthritis in the knee joint. This is the normal appearance of the knee and the medial meniscus, for example. But here you can see all these changes. There is significant narrowing of the joint space. There is denudation of the articular cartilage. Look here and you can see this is the articular cartilage, which is normal in thickness and normal in signal as well. But here you cannot appreciate the articular cartilage of the femur and the tibia. It is totally degenerated. Then subchondral ulcers, like these changes in the subchondral bone, these are known as subchondral ulcers or osteochondral defects. Marginal osteophytic clipping, and this is an example. This is an osteophyte, and this is also an osteophyte. They are prominent osteophytes. Subchondral pseudocystic changes, you may find some cystic changes in the subchondral bone which are not seen here. Bone marrow edema, and this is bone marrow edema secondary to degeneration, and then it can be seen in the tibia and femur or any of them. Intra-articular air or gas, which is the sequelae of degeneration of the cartilage, as it is seen also in the intervertebral disc. Here, this is the medial meniscus. You can see the anterior horn and you cannot see the posterior horn. It's totally degenerated with loss of its normal signal intensity compared to the normal appearance. Loose bodies are also seen in the major joints, and they represent the fractures of or the fractured osteophytes. Osteoarthritis by MRI, you see the osteophytes of the patella, you see the osteophytes of the femur and the tibia, and you got degeneration of the posterior horn of the medial meniscus, which is also torn. You can see this branching linear abnormal signal. And if you look carefully, you can see that the articular cartilage is almost totally lost with irregularity of the underlying bone. And you know that osteoarthritis of the shoulder are not that common. It is usually related to previously existing disease, but primary osteoarthritis is relatively uncommon compared to those of the knee. But the same manifestations can be seen by the plain X-ray, the narrowing of the joint space, subarticular bone sclerosis, prominent osteophytic clipping, and there may be subchondral or pseudocystic changes. You remember also from the lecture of the hip that one of the main manifestations of osteoarthritis in the hip is obliteration of the superior lateral aspect of the joint space, and this is important in the diagnosis. You can as easily appreciate the subarticular bone sclerosis, the irregularity of the femoral head contour, osteophytic clipping of the acetabulum and the femoral head. And by progression of the disease, you can see marked obliteration of the joint space, and this represents the subarticular pseudocystic changes. And here is osteoarthritis of the hip by the plain X-ray, and by MRI T1 and T2 weighted image showing almost the same manifestations: narrowing of the superior lateral aspect of the joint space, osteophytic clipping, subarticular bone sclerosis, and you can appreciate the pseudocystic changes by MRI more better than by CT. And also sometimes you may mistake the changes of avascular necrosis in the hip for those of osteoarthritis. You remember the main differentiating point is the superior lateral aspect of the joint space. If this part of the joint is maintained, and you see that the changes are totally confined to the femoral head, and you know that this is a vascular necrosis. But here you see that the superior lateral aspect is obliterated or markedly narrowed. There is osteophytes, there is subchondral bone sclerosis, and this is osteoarthritis. And this is the difference. This is avascular necrosis, and this is osteoarthritis of the hip. In this particular example, you can see the pseudocystic changes, which are well appreciated in the acetabulum as well as in the femoral head. And osteoarthritis of the facet joints and the neurocentral joints on the spine will present the same findings, except that you cannot see loose bodies here. You can compare this joint, which is showing on osteoarthritic changes, by this almost normal joint. And in the osteoarthritic joint, you can see narrowing of the joint space, subarticular bone sclerosis, osteophytic clipping of the articular surfaces, and interarticular air, as well as minute subarticular pseudocystic changes. And in the second patient, you can see bilateral, almost symmetrical osteoarthritis of the facet joints of at L5-S1 level. You know that the osteoarthritis of the facet joints in the spine are usually bilateral and symmetric, unless there is a particular cause like scoliosis, like poliomyelitis, for example, and this will lead to the development of osteoarthritis on one side compared to the opposite side. And osteoarthritis can also be seen in the sacroiliac joints with the same manifestations: the narrowing of the joint space, subarticular bone sclerosis, and osteophytic clipping of the articular surfaces. And here you can see bilateral interarticular air or gas representing the vacuum phenomena. You remember this abnormality, which is known as osteitis condensans ilii, where there is bilateral, almost symmetrical bone sclerosis of the iliac side of the sacroiliac joint, and the joint space is maintained. There is no articular abnormalities, and this abnormality is commonly seen in females after giving deliveries for many children, for example, and this is a stress manifestation in the iliac side of the sacroiliac joint. Is not considered a disease, but is a manifestation or the sequelae of multiple pregnancies. And you see the patient will present by chronic low back pain, and there may be some abnormalities in the mobility of the sacroiliac joint, and this is a self-limiting phenomena which may regress totally without treatment. And this is an example by CT and by X-ray. Bilateral is sclerotic reaction on the iliac side of the sacroiliac joint. The joint space is well preserved. The sacral side do not show any pathologic changes. And secondary osteoarthritis is the osteoarthritis developing on top of a previously existing joint disease, like infection, like trauma, like any kind of let's say surgery or endoscopy, for example. Then how can you know that this osteoarthritis is secondary, not the primary type? Of course, the history is very helpful, but these are the usual suggestions. You can see osteoarthritis in atypical location, an atypical age, and atypical appearance. You know, osteoarthritis is the disease of old age. Then, if you see osteoarthritis in in a young adult, you may suspect this. And also you see an uncommon location like that of the shoulder, as I have said before. And of course the appearance is usually atypical in terms of absence of significant osteophytic clipping, but and also you got severe abnormalities in the bone secondary to the previously existing disease. As you can see here in the hip, there is total loss of the femoral head, which is almost totally collapsed with irregular surface, and the joint space is severely narrowed. There is bone sclerosis of the iliac and femoral sides, and this is also an example. You feel that there is a previously existing disease here, which is commonly the septic arthritis. And after healing, you got bone sclerosis, and you got osteophytic clipping of the articular surfaces. You may see some subarticular pseudocystic changes, but where is the femoral head is totally collapsed or almost subtotally eroded or lost during the inflammatory process. Then we came to the issue of septic arthritis. Septic arthritis means that there is infection of the joint by any of these organisms: bacteria, rickettsia, viral, fungal, parasitic. Any of these types may result in septic arthritis, and we'll see the manifestations. Also, we'll mention some words about the traumatic arthritis, and we also will discuss the neuropathic arthropathy, and here are the common causes resulting in neuropathic arthropathy, as we will discuss later. And the organism may reach the joint by one of these routes: either the hematogenous spread or direct extension from an osteomyelitis in the adjacent bone, or by trauma or secondary to surgery. Then the most common organism for septic arthritis is the gonococcal infection, and the second is the staphylococcal type. It can involve one joint or more than one joint, and of course the best example nowadays for septic arthritis is the diabetic foot, where you got infection of the foot with infection of the soft tissues as well as the bone, resulting in osteomyelitis and septic arthritis of one or more of the joints. And here you can see an example of this metatarsophalangeal joint of the second toe. There is severe loss of bone density. You cannot see the joint space, and there is an extensive periarticular soft tissue swelling. Of course, you will see the manifestations of inflammation while examining the patient, like pain, tenderness, swelling, redness, and also fever. And this is the septic arthritis of the metatarsophalangeal joint, with follow-up after about 2 weeks, where you can see the degree of destruction of the joint itself, as well as the adjacent bones, the part of the phalanx, as well as the part of the metatarsal bone. And as I have said, the best example nowadays for septic arthritis is the diabetic foot. In cases of diabetes, there is a lot of reasons to contribute for infection of the foot, and there may be osteomyelitis or septic arthritis or both. And here, if you see the changes on one side of the joint, and you assume this is osteomyelitis, but if you see that the changes are on both sides of the joint, and you assume that this is septic arthritis. And this is septic arthritis of the metatarsophalangeal joint of the little toe. You see the erosions of the base of the phalanx, as well as the extensive erosions of the head of the metatarsal with the perosteal reaction. This is septic arthritis of the hip. You got haziness of the articular surfaces, narrowing of the joint space, erosion of the articular surfaces of the acetabulum, as well as of the femoral head. And this is septic arthritis of the shoulder on the right side. If you compare the right side with the left side, here you can see the capital epiphysis of the humerus, and you see the cortical bone of the proximal end of the humerus as well. But here you cannot see the capital epiphysis, and you see erosive changes of the proximal part of the humerus with extensive very articular soft tissue swelling. Then these are the manifestations of septic arthritis: soft tissue swelling around the joint because of inflammation, rapid destruction of the cartilage and bone, and then followed by joint space narrowing. And after healing, you got a sclerotic reaction of the articular surfaces, which may end by bony ankylosis. In diabetic foot, in diabetic foot, you see soft tissue swelling. You may got joint effusions, localized osteoporosis due to hyperemia, joint space narrowing, articular erosions, bony ankylosis if in cases of healing. And also you may appreciate that many of the toes or the finger of the toes are sometimes amputated. This is one of the classic appearances by CT of septic arthritis of the hip. I put this image to see the normal appearance of the acetabulum and the femoral head. But here in this case, the right hip joint is inflamed. The joint space is markedly narrow, markedly widened. There is diffuse bone sclerosis, irregularity, and collapse of the femoral head, and the joint capsule or the joint space is obliterated by this enhancing granulation, inflammatory granulation tissue. Also here, and you see this neonate presented by osteomyelitis and septic arthritis of the shoulder. You got this is MRI T1, and this is T2, and this is T1 post contrast. You can see there is diffuse soft tissue swelling and bone marrow edema of the proximal part of the humerus. And the T2 weighted image, there is a diffuse increase in the signal due to the inflammatory water content. And after injection of contrast, this is one of the best clues for infection, is the detection of what looks like an abscess. And here you see fluid collection, which is marginally enhanced, and also here you see a collection which is marginally enhanced. Then these two images may be mistaken for a tumor, for example, but whenever you inject contrast media and you got this very particular appearance of fluid collection with marginal enhancement, then you know that this is an inflammatory process. After healing, you got a narrowing of the joint space, bone sclerosis of the articular surfaces, marked irregularity, and may end by bony ankylosis. As you can see here, this is an inflamed hip. A follow-up radiograph showed that there is total bony ankylosis with loss of the hip joint space. And one of the types of osteomyelitis is the TB, which is commonly seen in the spine, but can be also seen in major joints, particularly the hip and knee, and also seen in other smaller joints. In the spine, I will discuss this in details when I'm talking about inflammatory diseases of the spine. But here you can see that there is involvement of the disc space as well as the adjacent parts of the above and below vertebrae. There is destruction and the erosion of the vertebral bodies with considerable narrowing of the joint space. Then around this site of inflammation, there may be a big cold abscess or collection of inflammatory caseous material. As you can see here in the CT scan, there is a prevertebral multiloculated collection, and also you can appreciate this cold abscess in the back muscles as well. Then by MRI, it is an easy diagnosis where you can see the disc space is affected and the above and the below vertebrae are also involved with the presence of intraspinal inflammatory granulation tissue as well as the prevertebral inflammatory granulation tissue and abscess formation. In the T2 weighted image, you see the collection which is extending in the prevertebral space. In the T1 post contrast, you can see the multilocular appearance with thick enhancing margins. TB of the joints, you can see this example of what is known as caries sicca, of the tuberculous infection of the shoulder joint. There is usually periarticular osteoporosis, and there is joint space narrowing, and there is marginal erosions with hazy articular surface. And in this example is you got erosive changes with periarticular soft tissue swelling in the capital humeral epiphysis. Also, this is considered one of the pathognomonic signs of TB, that it can cross the physial line. The TB osteomyelitis may affect the extremities, as you all know, and it may also involve the small bones of the hand and feet. And in children, metaphyseal foci can involve the gross plate, as you can see here, and this feature differentiates TB from pyogenic infection. Also, one of the particular appearances of TB in the hand is the presence of what's known as spina ventosa or TB dactylitis. There is involvement of the metacarpal or even the phalanx, and this involvement will appear in the form of considerable expansion and sometimes cystic changes and bone sclerosis of the involved bone. And this is an example of TB dactylitis affecting the proximal phalanx of the fourth finger with sclerosis and cystic changes and a very osseous inflammatory granulation tissue. This is one also of the well-known radiographic appearances of TB in arthritis, which is the hazy joint line. You can compare the normal appearance of the ankle joint. You can see the contour of the talus, and you can appreciate the cortex of the tibial epiphysis. But here you see what's known as woolness or woolly appearance or hazy appearance of the articular surface or the cortex of the talus, as well as the cortex of the tibia. An articular cartilage is involved relatively late, so joint space narrowing is also late in TB arthritis compared to pyogenic arthropathies. And this is also an example of TB arthritis in the ankle. You can see the hazy appearance of the dome of the talus as well as the articular surface of the tibia. The follow-up radiographs of TB arthritis of the knee joint. You can see the end result of joint space narrowing, severe periarticular osteoporotic changes, and in this particular example, you cannot see prominent osteophytes, for example, so that you cannot diagnose this as osteoarthritis. TB arthritis of the ankle, many cases have been presented, and you can see the typical appearance. And traumatic arthropathy, there are many manifestations of trauma in the joint, including periarticular soft tissue edema and contusion, fractures, joint subluxation and dislocation, joint effusion, intra-articular hemorrhage or hemarthrosis, intra-articular foreign bodies, intra-articular infection, post-traumatic deformities, and finally the secondary osteoarthritis. And you know that the Salter-Harris classification of fractures have been shown here. This is the normal appearance of the relation between the epiphysis and the metaphysis and the thickness of the physis. Then type 1 of this classification is in the form of epiphyseal separation with widening of the space between the epiphysis and the metaphysis. And type 2, there is metaphyseal fracture that extends to the physis. This is the fracture line. And type 3 is epiphyseal fracture that also affects the physis. And type 4 is the fracture affecting the metaphysis and the epiphysis across the physis. Type 5 is physeal compression fracture. You got impaction between the epiphysis and the metaphysis. I will show you some of these examples, and this is type 2 Salter-Harris classification with involvement of the metaphysis extending to the physis, and is best appreciated here in the sagittal proton density image. In the coronal T2 gradient imaging, you see bone marrow edema of the metaphysis as well as the epiphysis with some joint effusion. And this is a coronal T1 weighted image showing the edematous changes as well. And this is Salter-Harris type 4 fracture, which is crossing the metaphysis and the epiphysis, affecting the physis in between. This is not seen very well in the X-ray nor in the coronal T1 weighted image MRI, but it can see very well in the sagittal stair image. And you see this is the fracture line, which is crossing the distal part of the humerus, including the physis as well as the epiphysis. Of course, you see extensive bone marrow edema around the fracture. Then we came to the neuropathic arthropathy, this is known as the Charcot joint, and there are many causes for this neuropathic arthropathy, including sphingomyelia, meningomyelocele, spina bifida, spinal trauma, neurologic diseases, and congenital insensitivity to pain, intra-articular steroid injection, diabetes, brain injury, and leprosy. The X-ray manifestations are the combination of ischemia and the loss of sensation and the superadded infection. Then you got severe extensive derangement of the joint, and there is a lot of distortion of the articular relations. There are fractures and fragmented bones, and there are many appearances in the joint space, maybe widening or narrowing, but one of the particular manifestations is the presence of extensive bone sclerosis. And there is a large amount of bone and soft tissue debris in the vicinity of the affected joint, and you may appreciate also extensive periosteal new bone formation. The changes are sometimes be simulated as if you have hit the joint by this hammer, and you got too many fractures, you got destructive changes in the bones. As I have said, the bone sclerosis is one of the main issues here in the neuropathic arthropathy, and you get periosteal reaction, of course, and extensive soft tissue abnormalities. And also here you can see this is assumed to be the knee joint. There is a considerable derangement of the knee joint, which is totally dislocated. This is the patella, and this is the femur, and this is the tibia. You got destruction of the joint, extensive areas of bone sclerosis, periarticular soft tissue swelling. And you may use CT to appreciate more the degree of extensive bone destruction compared to the normal side. And this is the Charcot on the right side. This is the normal foot on the left side, and you may have, of course, the 3D images in color. This is also a Charcot arthropathy, which is, according to the literature, is characterized by 5 Ds: disorganization, destructive changes, debris, density increase, bone sclerosis, and the deformities. And you can see here all the manifestations. Charcot joint, and this patient had a prior femoral fracture, and he has developed Charcot joint in the knee with the changes as have been described. If you use MRI, you will not, I think, you will not add too much to the findings of the plain X-ray. You may be able to see more extensive destructive changes and more bony fragmentations. And in between these, you may see some fluids or inflammatory granulation tissue. These are the neoplasms which can occur inside the joint, like synovial sarcoma, lipoma, hemangioma, neurofibroma, synovial chondrosarcoma, primary juxtaarticular bone tumors. We have discussed this before: metastatic diseases, leukemia, lymphoma, and myeloma. And you remember the synovial sarcoma is a malignant disease affecting the synovium. It can occur in any of the joints, and that diagnosis is usually made after biopsy. You got a lesion, and this lesion will show low signal in the T1, high signal in the T2, and it will show contrast enhancement. It may contain some foci of calcification. And this is an example of synovial sarcoma, which is located in the popliteal fossa. T1 weighted image, T2 weighted image, and T1 post contrast with fat suppression. You got invasion of the neurovascular bundle. And here is the popliteal artery and vein, which are almost totally encased by the tumor tissue. And this is synovial sarcoma in the sole of the foot. You got the same appearances: low signal in the T1, high signal in the T2, and heterogeneous post-contrast enhancement in fat-suppressed T1 post-contrast images. Of course, you know that you will got the diagnosis after biopsy in most of the cases. And synovial hemangioma can also occur as an intra-articular pathology. You remember that hemangioma is usually of a very bright signal in the T2 weighted image. Hemangioma is usually a creeping lesion that can spread within the joint. It will show intense post-contrast enhancement with evident high signal in the T2 weighted images. Also, and here you can see this is the hemangioma, which has a creeping nature between the muscle and the joint. Also, you have heard about the lipoma arborescens. When I discussed the knee joint. And this is MRI T1 sagittal of the knee and T2. You got synovial fluid with intrasynovial branching fat signal mass, and this is known as synovial lipoma arborescens. And you remember the difference between synovial lipoma and lipoma arborescens. Lipoma is just a mass, while arborescens is a branching fat-containing lesion within the synovium. Also, you remember chondroblastoma is a tumor of epiphyseal distribution. It is very close to the joint, and it occurs particularly in the epiphyses. And whenever it is large, it will extend into the metaphyses. As you can see here, the tumor is sometimes surrounded by evident bone marrow edema, which will show low signal in the T1 and a high signal in the T2 weighted image, as you can see in this particular example. Then osteosarcoma is a metaphyseal pathology which can invade the epiphyses and can also invade the joint. And this is an example of osteosarcoma, the proximal part of the tibia. And in the plain X-ray, you cannot appreciate invasion of the epiphysis, but here in the MRI, you can see that the epiphysis is almost totally infiltrated except for this very small area, and consequently the tumor has breached the cortex and extended inside the joint. This is the remaining images of the same case. You can see invasion of the tibia, invasion of the joint, and you can also appreciate the extraosseous soft tissue component surrounding the bone. And here you see the extraosseous soft tissue component well appreciated in the axial image. Finally, we came to the miscellaneous disorders. We want to discuss the pigmented velonodular synovitis, synovial osteochondromatosis, and some of these particular issues. You remember that the pigmented velonodular synovitis is an idiopathic monoarticular disease which occurs in many joints and particularly in the knee, and this is one of the common locations for the pigmented velonodular synovitis. You develop multiple synovial masses of low signal in the T1 and T2 weighted image, and if you inject contrast, they may show contrast enhancement. And this is focal, not pigmented velonodular synovitis in a typical place, which is the infrapatellar bed of fat. Along the anterior aspect of the joint line, there is a lesion of low signal in the T1 and also low signal in the T2 weighted image. And this is also considered the classic appearance of pigmented velonodular synovitis, and you can see multiple low signal masses in the anterior and posterior compartments of the joint. Synovial osteochondromatosis is a disease resulting from synovial metaplasia leading to the formation of cartilage, which will then calcify. The major joints to be affected by this disease are the knee, the hip, and the elbow. And the diagnosis is based on the presence of multiple calcified loose bodies within the vicinity of the affected joint. And sometimes this appearance is related to the popcorn appearance because of the close similarity. Here is a good example of synovial osteochondromatosis with too many loose bodies calcified in the anterior part of the joint as well as in the posterior part of the joint. With the onset of the disease, you may get widening of the joint space because of the presence of these loose bodies. Then the loose bodies may erode the bones, and finally you got secondary osteoarthritic changes. This is the typical popcorn appearance of synovial osteochondromatosis of the knee joint by a plain X-ray. You can also diagnose this by MRI, knowing that loose bodies will appear of low signal in the T1 and T2 weighted image unless they are large, then they will develop a bone marrow cavity and a cortex, as I have mentioned. Osteochondral ulcer is a lesion affecting the chondral bone as well as the articular cartilage as well as the subchondral bone. And this ulcer may be associated with evident bone marrow edema, as you can see here, low signal in the T1 and high signal in the T2 weighted image. And osteochondritis dissecans is a vascular necrosis affecting commonly the medial aspect of the medial femoral condyle, resulting in ischemic necrosis of a part of the condyle, ending by separation of the dead bone, which may be dislocated in the joint, forming a loose body. And this is osteochondritis dissecans. There is separation of the articular cartilage as well as the underlying bone. This is an example by MRI. You got a separation of the ischemic bone, and there is some fluid between the bone and the mother bone, which is one of the criteria of unstable fragment, as I have mentioned before. And to remind you, these are the criteria of unstable fragment of osteochondritis dissecans. If the fragment is larger than 1 centimeter in size, if there is fluid at the fragment base, if there is cystic changes at the donor site, and if there is enhancement of the separation line. Also, a vascular necrosis of the talar dome we have discussed before when we said we have 4 types or 4 grades of avascular necrosis of the talus, including grade 1 diffuse bone marrow edema, grade 2 separation of the dead bone from the viable bone by a line, then separation of the dead bone from the bone itself, then displacement of the separated necrotic bone. Then this is an appearance of grade 2 avascular necrosis of the talar dome. You got the line separating the dead bone inside, which is of fluid signal, from the viable bone outside. Finally, this disease is also one of the arthropathies, which is known as hypertrophic osteoarthropathy, which indicates the presence of extensive diffuse preosteal reaction along the short and long bones related to some pathology, usually in the chest, but may be also seen in other parts in the body. And this is an example, and you can see this patient had a mass in the anterior mediastinum, if you look here, and this was a lymphoma. In the radiographs of the leg, if you look carefully, you can see the diffuse lamellated preosteal reaction along the shafts of the tibia and the fibula. And this patient had a bronchogenic carcinoma with typical appearance, pulmonary nodule with a speculated margin, as you know. And here in the forearms as well as in the leg, you got extensive fluffy like or irregular preosteal reaction along the tibia, the fibula, the ulna, as well as the radius, and also in the metacarpal bones. This is known as hypertrophic osteoarthropathy, which is related to some of the malignancies in the human body, usually in the lung, but may be located elsewhere. Alhamdulillah Rabbil Alameen. Thank you very much. Wassalamu alaikum wa rahmatullahi.